Good morning, everybody. It's right at 10, so I want to be mindful of everybody's time. Thank you again for joining us for our third and last webinar in our expansion webinar series, hosted by the Western Kentucky Opioid Task Force. Um, my name is Cameron Berkey, and I'm the project manager for the Purchase Health Department. And once again, I did want to thank all the attendees, those who have shared the flyer, as well as each and every one of our speakers. Today, we are joined by Ms. Shaina Doyen. She is sorry, Shaina Doyen is currently the assistant manager for antimicrobial stewardship at Baptist Health. She graduated from the University of Louisville with a bachelor's degree in chemistry and obtained her doctor a pharmacy degree from Sullivan University College of Pharmacy. She completed her postgraduate year one residency at University of Louisville Hospital and postgraduate year two residency specializing in infectious diseases at Norton Healthcare. She is the co-chair for the Infectious Disease Council for the Baptist Health System and supports antimicrobial stewardship initiatives across the system for inpatient and outpatient services settings. But before I hand it over to her, wanted to do a little bit of housekeeping. So if you have joined us in our previous webinars, it's basically going to be the same default settings as those. So we do have the Q&A submission feature button enabled. So we do ask everybody to use that button to, ask your questions, which will be addressed at the end of the presentation. Also, if you feel more comfortable coming off mute, I can allow you to come off mute at the very end when we open that up. Also, we do have the chat enabled as well for any side comments, or if you just feel the need to introduce yourself and tell us where you're calling in from. So, without further ado, I would just like to hand it over to Shaina Doyen, who's going to be taking us through Breaking Hearts, the deadly link between drugs and endocarditis. Thank you.
Thank you so much for that introduction, and I'm really excited to talk about this important topic with you today. And please, I think to what Cameron said, I'd love to hear where you're calling in from and what your relation is, or if you're currently in practice, what your current practice is. And I do want to slightly apologize, have a little bit of some laryngitis. I'm hoping that I can make it through the presentation today, but thank you all so much for joining us. So I know that we've got a pretty broad group of individuals that we'll be talking to today. So I'm really going to try to keep it at a basic overview of what endocarditis is and its association with IV drug use. We're really going to talk about why it happens, how it's treated. Of course, that's my area of specialty, so I'm going to focus a little more on what newer evidence is showing and how we're able to be a little more creative, or at least where it's pointing in that direction. And then lastly, one of the most important aspects of that is ensuring that we're providing patient support. So we'll briefly touch on that at the very end. So endocarditis is a serious infection of the heart's inner lining, or the endocardium, and it does often affect the heart valves. And how this happens when there's bacteria or fungi that enter the bloodstream and actually stick to the heart. And unfortunately, once it sticks, it can cause damage to those heart valves, and then ultimately causes some life-threatening complications. And we'll kind of walk through what those are. We really want to know why does IV drug use actually put you at higher risk of getting endocarditis? We know with IV drug use that injecting drugs with unsterile needles, unfortunately, any type of introduction into the bloodstream does put any patient at risk if it's not done appropriately. But when you're utilizing unsterile needles, this does introduce pathogens. And so this is bacteria or fungi that may be introduced into the bloodstream. And we know with any dirty needles, this is high risk of infection. And IV drug use significantly increases this risk because there's repeated exposure. So it's not just a one time, but there's often repeats. And what unfortunately happens is with those repeats, it's causing repeat damage to those heart valves, making them vulnerable. And then the last piece being that there's not a direct blood supply that helps to fight off that infection, unfortunately. So looking at the pathophysiology of endocarditis, what ultimately happens, and I have a picture here on the right showing the aortic valve. Really, with IV drug use, what we see, it often causes right-sided endocarditis. That tends to be more common, but this was actually a really nice visual to kind of see how endocarditis can occur. But typically, bacteria or fungi enter the bloodstream, and this is through the actual injection. The bacteria or fungi will adhere to the heart valves, and so you can kind of see here on the right where this adherence occurs. It forms what are known as vegetations, and so I may refer to that another time throughout the presentation, but this is what that is. It's essentially clumps of bacteria or fungi, fibrin platelets that can adhere to those valves. What unfortunately happens is those vegetations can actually damage those valves. And then it can cause emboli and then cause spreading of infection throughout the body. And so I'll touch on here the unfortunate effects with acute symptoms and even signs of complications as the infection continues. So with acute symptoms, what patients may see are high fever, chills, night sweats, maybe tired, weak, have some shortness of breath or even chest pain, just depending on where the infection has spread. And those, as you can kind of see, are what we may consider to be pretty nonspecific. And so sometimes it can be really, really challenging to pin down without looking at a patient's history. But that can be pretty helpful, and we'll talk about that in just a minute. As the patient continues to exhibit these symptoms, there are some later complications that can occur. So I mentioned the emboli, so septic emboli, that can be pretty common in the form of informed lung abscesses in patients that are big clumps within the lung. In patients that do have right-sided endocarditis, and so this can be pretty common for patients who inject drugs. And then some additional complications that can unfortunately occur. So Janeway lesions, these can be some painless spots that can occur on the palms or soles, and so you can kind of see this picture here. And then ulcer nodes, these are painful red nodules that can occur on the fingers and toes. And so you can see what these look like here. And then what's known as Ross spots, so retinal hemorrhages, you can see where those hemorrhages can occur in the eye. And so as I mentioned, they tend to be more complications that occur further down the line if it's not been diagnosed. So as I mentioned, there can be some variability, some very nonspecific symptoms when the patient presents. It can make it very challenging to diagnose, but getting that early and accurate diagnosis is a necessity. Just as I mentioned, some of those complications that can occur further down the line if it's not diagnosed early enough. Blood tests, or what we call blood cultures to help find bacteria in the blood, are also an important necessity for diagnosis. Heart ultrasound, or what's known as an echocardiogram. There's two different types that are utilized, one being a little more accurate and invasive. This helps to look for the infection on the heart valves. So a TTE versus a TEE. And then there's also Duke criteria for endocarditis diagnosis. And so there's a major and minor criteria for evaluation, and I'll kind of go over some of that here in just a minute. And then lastly, if providers suspect other complications, then they can perform other tests such as a CT scan or an MRI. So I mentioned the modified Duke criteria. So I think the big question is, what is this? If you're not familiar with this. So this is actually diagnostic criteria that was originally proposed in 1994 by Dirac and colleagues from Duke University Medical Center. This is actually, as you can kind of see, it was quite a long time ago, and there have been several refinements to this criteria, and they're always making updates to this. But there are actually three different pieces to this. So we have a definite, and so they utilize pathological criteria and then clinical criteria. I'm not going to include all of the specifics with this, and this can all actually be pulled from the IDSA guidelines for reference if you're interested. There's also, secondly, the possible, and this is mainly just based off of clinical criteria. And then lastly, it would be rejected if there's a firm alternative diagnosis. Resolution of the syndrome within less than or equal to 4 days of antibiotics. No pathological evidence or does not meet criteria for possible endocarditis. With endocarditis, it is a heterogeneous disease that is highly variable, as I mentioned with the clinical presentation. And so the use of this criteria alone for diagnosis should not occur and should be a compilation of all the things that we discuss. So there are some common pathogens that are associated with injection drug use. Staphylococcus aureus or Staph aureus, and then some other terms that may be more familiar with this might be MRSA or what people would call as MRSA or MSSA infections. Streptococcus species is also one that is pretty common, and I actually added some the gram stains that we look at in the microbiology lab when say we pull blood and maybe in the blood we look at that under a microscope, and this is what these look like. So typically these are in clusters and you see these in chains. And then gram-negative bacteria, not as common as our gram-positives, but can occur. But Pseudomonas aeruginosa is included within that. And then, as I've kind of mentioned throughout the presentation, fungi can also cause it, but it's not as common. There are some other epidemiologic clues for helping to define a pathogen. So normally, when a patient presents, we tend to initiate treatment. We call it empiric treatment initiation. So this is when we, based off of the data that we have available, can look at a patient's risk factors and sort of what they do on a daily basis and kind of define what potential pathogen we may be treating. In some cases, we could be treating what are called a culture negative. So we may get blood cultures, but maybe don't isolate a pathogen, in which case we have to utilize a tool such as this to help determine what type of antibiotics to start or antimicrobials to start. And so I've listed some common epidemiologic clues that help to define that here. The IDSA guidelines actually have each of these listed out with common pathogens that are associated with each of these. And that can be referenced, and I've got that listed here. So when we look at treatment, the most important piece of that is just ensuring that you have a complete management team for that patient. And of course, with infectious disease, that's sort of going to be my focus for today. But as a part of the team, you'll have a combination of cardiologist, ID. There could be some social workers. There's really a full team that helps to manage these patients to ensure they're fully taken care of. But as a part of infectious disease consultation, we ensure that this is obtained. And really, as I mentioned, Staph aureus is one of the most common causes. And in order to ensure that we define the most optimal empiric regimen or that initial treatment regimen at the start of therapy, having that ID consult is certainly very important. And as I mentioned with Staph aureus, we actually have numerous studies that have shown a decrease in mortality or death, decrease in hospital length of stay, infection relapse rates or the infection occurring again, an increase in adherence to our standards of care. So we really have a standard of care with how we manage Staph aureus bacteremia as well, that result in the best outcomes for our patients. And we have good data that shows that with that ID consult, all of these good outcomes occur. So having that ID consult is very important if it's available. Typically with the start of treatment, as I mentioned, we start with empiric therapy and then we change to a targeted regimen based on whatever culture we isolate, or pathogen that we isolate within our culture. Common antibiotics that we typically use for, as I was kind of mentioning with Staph aureus, it's really based off of resistance patterns or how we know whether an antibiotic is going to work for a bacteria. But with Staph aureus, there are two that we're concerned with. So MSSA infection or methicillin susceptible Staph aureus, we can use nafcillin or cefazolin. Cefazolin is better tolerated or has been than nafcillin, but nafcillin is also a good, pretty tolerable therapy to utilize. Methicillin resistant Staph aureus or MRSA infections tend to use vancomycin or daptomycin. Streptococcus species is also another where we could utilize based off of how susceptible or resistant and then what options we have available from an administration standpoint. Penicillin G or ceftriaxone. Ceftriaxone tends to be a little bit easier from an outpatient perspective. On patients, if say a patient doesn't have the ability to get penicillin G from like a continuous infusion administration, and so that tends to not really be as favorable in this patient population. And then there are other antimicrobials that we can consider depending on what is isolated. So I'll very briefly go over some of the treatment considerations within IDSA guidelines, but as I mentioned, there are some treatment aspects that I really wanted to try to focus on that are part of some of the newer data and discussions that help make things easier for this patient population. But within the IDSA guideline recommendations specific to right-sided infective endocarditis in patients who inject drugs, for the treatment of uncomplicated MSSA, right-sided, short course therapy can be considered. So I'll kind of talk about here in a bit. With the treatment of endocarditis, it historically has really been recommended to treat it for a little longer, so anywhere from 4 to 6 weeks. But it actually has been found that for this type of endocarditis, in particular, that short course therapy can be utilized if you utilize what's known as a parental beta-lactam. So I had mentioned the nafcillin and cefazolin in the beginning. Or if daptomycin is available, then either of those are adequate to be utilized for a 2-week course, as long as it's uncomplicated. For the treatment of MRSA right-sided, short course therapy with a glycopeptide or vancomycin is what you may be more familiar with. It may actually be less effective, so we tend to utilize longer durations for that. For those caused by Staph aureus in the absence of prosthetic material, Gent is actually not recommended as an adjunct in therapy. The addition of gentamicin to the recommended therapy was previously recommended, but the current evidence has not actually demonstrated that it's better to utilize as combination compared to monotherapy or just utilizing nafcillin or oxacillin. Or cefazolin in those instances, as I mentioned, that's also another option. And really with the addition, it's actually been associated with renal toxicity. So really the conclusion with that is that it's really unnecessary to add it because it actually hasn't shown additional benefit and may actually cause additional harm. And as I mentioned, that's in the absence of prosthetic material. And then IDSA guidelines statement from the guidelines from 2015, it actually states that in patients who cannot be sent out on IV antibiotics, oral treatment may be a reasonable option. And so I did add this the date here because the guidelines were most recently updated in 2015. And as I mentioned, we kind of try to utilize as much newer data as possible to care for patients. And so throughout this, I've tried to add the various dates as I kind of go through updates. But even back to 2015, they're already talking about the option in patients that it is reasonable to do so. They can be sent out on oral treatment. They talk about the use of ciprofloxacin plus rifampin for an uncomplicated right-sided MSSA infective endocarditis in patients who inject drugs for around 4 weeks. And this does have a cure rate of greater than 90%. I think the biggest barrier, unfortunately, with this recommendation and what we see is that fluoroquinolone resistance is actually quite high for Staph aureus and isn't typically a therapy that we can utilize for that. So as I mentioned, I'm going to talk about some newer data here. So this was actually a pretty big landmark trial in this world. So the POET trial came out in 2018. So this is looking at partial oral or IV antibiotic treatment of endocarditis. And I know, as I mentioned in the very beginning, I was trying to keep the presentation as basic as possible. So I'll try not to get too scientific. The slide looks very scientific here, but I'll try to keep it as basic as possible. But there's a pretty considerable amount of patients included in this trial. You can see 400 patients. Unfortunately, have left-sided infective endocarditis, but still very important landmark to kind of show that this is an option. When we look at data, we of course want to look at the patient population, how many patients were included, and then in specific for endocarditis, what type of pathogens were isolated, and then what kind of treatment did we use. And so for this in particular, you can see that we looked at streptococcus, enterococcus. That's one that I didn't necessarily mention in the very beginning. Staph aureus, I know I've mentioned quite a bit, and then coagulase negative staphylococci is also another, to consider. And then this does talk about a little bit, it's pretty much split half and half between the groups. So they look at IV therapy and then compare it to oral. So as a part of the study protocol, these patients did receive at least 10 days of IV therapy before switching over to oral. So that's an important part of consideration. So just understanding that this data, when applied, patients did receive at least 10 days of IV before switching to oral. So I have what they looked at is what's known as the primary outcome composite that was defined. So when we look at outcomes and how well this intervention may have performed, they look at patients, if they passed away for any reason, had any type of unplanned cardiac surgery, an embolic event, or relapse of bacteremia or blood in their bacteria in their blood, with a primary pathogen that we talked about at the very top. So any of these bacteria here, from randomization to 6 months after treatment is completed. And then I'll kind of talk about 5-year outcomes here in just a second. But when looking at the results of this study, the median duration of therapy was 19 days in our IV group, 17 days in the oral group. So it looks like from a treatment perspective on average, received 10 days of IV therapy and then completed the rest with oral. Non-inferiority criteria were met. And so what this means is that there's no difference between the groups. And so this is a positive thing, showing that that partial oral treatment is an option, could potentially be an option for specific patients. So as a part of the POET study, they actually did 5-year outcomes. So they followed up the study to find out if there were any indications of treatment failure longer term. So looking at 5 years. So you can kind of see the 5-year outcome with this primary composite. So occurred in the oral step down and around 33% of the time, and then 45% in IV treatment groups. There was a difference. They actually did find that there was a lower incidence of death from any cause in the oral step-down group, so 23 versus 35% respectively. And there was no difference noted in any of the other defined outcomes that I kind of listed that were listed here. And the positive part is that there were no indications of longer term treatment failure in those patients that did receive oral step-down. So then there was another multi-center retrospective cohort study that was published in 2023. And really, this was looking at a real world application of providing oral therapy. And so this was a little bit smaller. There were 211 in the IV group and then 46 in the oral therapy group. The oral therapy was provided to stable patients with no contraindications. There were some group differences between the two. The IV only had older patients with more comorbidities. The oral antibiotic group did have a higher proportion with a history of injection drug use, which could be helpful, obviously, in the patient population we're talking about today. They did perform a multivariable regression analysis, which is essentially a fancy way of saying they analyzed the data to find out if there was an impact. And it showed that it shouldn't cause any type of significant impact on the outcomes that they found within the study. But I do have this caveat statement with any data that, of course, anything that is unmeasured, it can't be accounted for, which is what the study said. But when looking at the results here, they looked at a primary outcome measure of clinical success at 90 days. You can see here that it was successful in around 84% of the time in the IV, and then 87% in the oral group, which is great. Secondary outcome measures, they looked at clinical success at last follow-up, adverse events, hospital readmission rate within 90 days. You can kind of see each of those listed here with similar comparison. One notable mention, though, adverse events were significantly lower in the oral group. And then, each of these, there were no differences, which is sort of what we want to see in this kind of study. And then I added this as an extra for reference. So there is a nationally known ID physician named Dr. Brad Spellberg. And so he's actually pretty well known for his shorter is better, or looking at duration of therapy really to minimize unnecessary prolonged antibiotic courses. And looking at the newest data to say that we can use shorter courses of therapy versus longer. But he also has quite a bit of references available on when we can utilize oral therapy for treatment of infections that we would have historically used IV therapy for. And so I added this table. I thought it was a really nice table, an overview, sort of as the various studies, really well done studies that we have available, showing that we can successfully utilize oral in the right patient population. And so I have the authors listed here, and as I mentioned, since we're going to be looking at timeline and kind of how it's progressed over time, the years that those were published, and then number of patients included in the study, the type of regimen that was used, because as I'll kind of talk about in a second, that's very important. And then its comparison, and then what type of success occurred in that study. And so really overall, you can kind of see there's quite a bit of variability, but most of that really is due to patient variability in each of the studies, because that can't always be controlled. But overall, when you kind of add up all of the very big studies that are included here, we have around 864 patients in total. And then for the treatment regimens, you can kind of see, we'll talk about here in a second, most of the oral regimens or antibiotics that we know have what's considered to be a high bioavailability. So what we know is that they reach really good drug concentrations within the bloodstream and then site of infection that is similar to us giving a drug intravenous. And then over here is success rate based off a study. And really overall, as you can kind of see, we have it's oral versus IV and oral still, even with the compilation of all of those studies, is still shown to be very successful. So really, when we look at the final conclusions for this discussion on oral therapy, we know that, so we have 3 randomized clinical trials that have established a transition from IV therapy to oral. And this has been shown to be at least as effective as IV-only therapy. We know with our pharmacologic data, many of the oral antibiotics that we have from the data have they have that high bioavailability, as I mentioned. So they can reach those high levels, high drug levels within the blood. And typically, when we treat something, we want to ensure that the drug levels exceed what the minimum inhibitory concentration, or an MIC, of the pathogen, so that we're able to adequately treat the pathogen and then not have the pathogen overcome the antibiotic. And then lastly, so there have been also numerous observational studies that have demonstrated favorable outcomes, and one we actually just reviewed using oral treatment for infective endocarditis. And so, as I kind of mentioned, I was going to skim over these 2 components. There really are 2 important factors to consider. There's really a lot more, but there are 2 that I really wanted to touch on today. And really, one, not all antimicrobials are created equal. I talked about bioavailability. And then 2, giving oral therapy may not be appropriate for all patients. So we'll touch on not all antimicrobials are created equal first. And so I actually provided this table to kind of talk about, some of the most common organisms that we'll typically see. So strep and staph species. And as I kind of mentioned, I mentioned that term MIC. So it matters when we select treatments. So it determines whether or not an antibiotic can be used for a particular pathogen or bacteria. And so you can kind of see that listed here. But if it's sensitive, we have these oral options here. If it's intermediate or it's enterococcus, so this tends to be a pathogen that can be a little more challenging to treat, then we can utilize these antibiotics. And then you can kind of see the difference. So with a highly sensitive one, there is that option where one drug can be utilized for native valve. And then we start to see the options kind of increase with 2. So rifampin can be added as an adjunct to help treat. And then for resistant, I have those listed here. And then if amoxicillin is not an option for enterococcus, then that does push us into utilizing a drug such as linezolid. For staphylococcus species, then we've got sort of a slew of options available depending on what type of resistance patterns we may see. And then additionally, and I did want to mention, and I think I know I've said this a few times, but each of these drugs are listed here as options because they do have that high bioavailability and do reach those adequate concentrations. And you can kind of tell that, particularly with a lot of these drugs, that we are using higher doses and higher frequencies, particularly for the beta-lactams, to ensure that we're reaching those adequate concentrations. The second piece is, as I mentioned, this may not be an appropriate option for all patients, so utilizing oral may not. But there are some reasonable patient selection criteria that can be utilized. So clinical stability with no immediate indication for procedural source control or cardiac surgery. If we've seen that the bacteremia is cleared or it is clearing without that need for source control or that need to take the patient to surgery, an oral antibiotic regimen is available. So as I mentioned, sometimes we've got resistance issues, especially if a patient's had a pretty significant history of receiving an antibiotic for any reason. It may be more challenging to treat, especially if they've had recurrent cases of infective endocarditis. That tends to be a little more complicated. If the patient is likely to absorb the antibiotic, so if we do take an antibiotic orally, we have to make sure that their GI tract is functioning well. And then lastly, if just making sure that we don't have any socioeconomic determinants or inequities that could render them, it's necessary for them to receive IV therapy. So as I mentioned, some of the IDSA guidelines in the very beginning, as we kind of transition back to those, there are options for us to receive those 2 weeks. But when we look at treatment duration, length of therapy is really dependent on a number of different things. So pathogen is important. I kind of talked about, the differences of Staph aureus. Is it susceptible? Is it resistant? So MSSA, MRSA, Streptococcus species, Enterococcus. There's a number of different pathogens that we consider. Does the patient have their native valve, or have they had to go in for surgery and now they have a prosthetic valve in place, or do they have any type of prosthesis at all? And then, of course, the antibiotics that you select, we kind of talked about at the beginning that can kind of determine your duration of therapy. You also want to ensure that you obtain at least 2 sets of blood cultures every 24 to 48 hours until the bloodstream has cleared. And the purpose of this is really that your duration of therapy, you determine that based off of the clearance of blood cultures. So typically you can begin counting on the first day blood cultures are negative. In cases where you did have blood cultures that were initially positive. And those culture negative endocarditis cases that can be obviously more challenging. And then lastly, most routinely, this is given through an IV. We talked about the oral option for those select patients, but typically duration of therapy can be anywhere from 4 to 6 weeks in the hospital or at home, dependent upon each patient scenario. And we did talk about those 2-week circumstances as well. So I'm just going to briefly touch on this because there are some circumstances when surgery may or may not be needed. And sometimes, it's a discussion with the surgeon and maybe it could be a specific patient case scenario. Some people need heart valve surgery for repair or replacement, and it could be due to, if the infection damages the valves too much and that leads to heart failure, then they need it, to keep functioning. If a patient has large vegetation, so they say if it's greater than 10 millimeters, that may be an indication for surgery. If the infection is uncontrolled despite antibiotics, the last slide I talked about what we call source control. Sometimes antibiotics just won't cut it. So you can give all the antibiotics, every antibiotic for as long as possible, but sometimes you just can't overcome the bacteria and you have to go in and remove it surgically. And then lastly, recurrent endocarditis due to ongoing IV drug use also could be a reason, but this also can be relatively controversial. And so the big question is, can endocarditis come back? Unfortunately, yes. And this is especially if IV drug use continues. But sometimes even without continued use, unfortunately, repeated infections, as you can imagine, does destroy the heart valves and lead to heart failure. And ensuring that we're preventing any type of repeat infection is just as important as preventing the first infection that the patient may get. So how do we reduce the risk? Really, the most important part is, if able, we want to stop the IV drug use. If there's any way that we can provide support to help patients seek additional treatment and rehab counseling, provide medications, we want to ensure that that's available to them. And then, of course, using clean needles if the patient's still using. So needle exchange programs really do help because if we're not going to stop, then ensuring that we're using clean needles can help reduce contamination and reinfection or infection to start with. Just getting regular checkups to monitor heart health can really help. And then ensuring that we're practicing good hygiene and taking care of wounds properly. And this really can be, when I say practicing good hygiene, not just with the wounds, but even just showering and practicing even good oral hygiene can be helpful. So really, we know that there are a number of challenges, but so with those challenges, we know that there's really a high recurrence rate in patients that do have ongoing drug use. And many people struggle with addiction, and it does make it hard to complete the treatment courses. And a lot of times, with the antibiotic courses being so prolonged, we tend to have poor adherence to those treatments, which complicate it. As I kind of briefly mentioned, there are some ethical dilemmas in valve replacement in patients that have continued IV drug use. There's really sometimes some hesitation to do those surgeries for people who continue using IV drugs, and this is really just due to the fact that it really places the patient at risk for continued complications. And then additionally, the last piece, as far as challenges go, there are long hospital stays, IV antibiotics that can be challenging to coordinate. Patients often won't stay for the entire treatment, and it can often be pretty expensive, not only for for the patient, but also for the hospital. So what we want to ensure is that we have harm reduction strategies available for our patients. And so I mentioned needle exchange programs to help prevent reinfection. And I've got here from a paper that was published from one of the lead authors from the IDSA guidelines. This table that goes over some of the key points for safer injection drug use. So, just communicating not to lick the needle, not to lick the injection site, using sterile water or water from an unused water bottle for drug preparation, because even utilizing tap water, unfortunately, can cause that contamination. Ensuring that the needle is sterile, cleansing the skin with alcohol pads before injection if possible, avoid high-risk injection sites. So, the safest injection sites being on the hands, arms, and feet or legs, and not to use substances when you're alone and carrying naloxone. And then there are some useful links that are listed here for additional resources as well. And then also kind of there's additional, harm reduction kits that can be compiled, but I did want to be sure to communicate an important note that really need to recognize which interventions are legal according to state laws, because there are state laws that limit that. And then the last two pieces here are just ensuring that there's access to addiction treatment. So Your examples are methadone and buprenorphine. And then education on safe injection practices to help reduce that bacterial entry. So really prevention is the best medicine. So the best way to avoid endocarditis is to prevent infection. Um, Providing early addiction treatment and rehab to help reduce IV drug use really can save lives. And it's not just on the risk of the drugs, but then the unfortunate after effects if a patient were to actually get infective endocarditis. There's really a lot of long-term management associated with that. There are programs to help. If you are a patient that is struggling or a family member that has someone you love that is struggling with this, don't be afraid to ask for support. And there are additional long-term support systems and management that can help as well. So ensuring long-term follow-up for heart valve monitoring, and then any type of psychosocial support to help address the underlying substance use disorder is available. So please do not be afraid to seek that out. So in conclusion, infective endocarditis in patients who inject drugs is a serious but preventable condition. Treatment does work, but after repeat infections, it tends to get relatively complicated, and the detrimental effects unfortunately happen very quickly, and mortality is quite high if we're not able to treat that. And really, stopping IV drug use is key just to avoid reinfection. As I kind of mentioned in the beginning, multidisciplinary approach. So having cardiology, infectious disease, addiction medicine is crucial to managing and supporting our patients. And then harm reduction and addiction treatment do play key roles in helping to prevent that reoccurrence. And that is all I have. And I'll take any comments or questions if you have them. Appreciate your time today.
Yeah, so we'll open it up to questions. You're very knowledgeable, Ms. Shaina. Looks like we do have a question that came in. So, um, there are some like gaps with insurance that we all are aware of in Medicaid with some of our clients in harm reduction. So, what might be some gaps, I guess you would say, that could hinder or prolong treatment of an individual?
Um, is so in relation to like insurance not covering.
Yes.
Um, so I would say in a majority of circumstances, if we have issues with like if the question maybe is referring to coverage in like an outpatient perspective, like providing IV antibiotics outpatient, um, I would say a majority of the time, most hospitals or health systems try to keep a patient if they're willing to provide that treatment to them. But as I kind of went over some of the unfortunate challenges with that, I know patients don't want to stick around. It can be challenging to stay in the hospital. Can be challenging to continue for weeks at a time to receive that treatment, and can be, challenging for the patient and the hospital. And I'm assuming also just in regards to insurance support, that there's, you mentioned harm reduction and even addiction treatment. If there's some limitations, I'm not as familiar with insurance coverage as it relates to that, but can imagine that, at least with some of the challenges we see from an inpatient perspective, like within the hospital, I would assume that we also see some challenges with insurance covering that. I'm not able to speak to that directly, but can certainly say that I know that there are various tools and available to try to help support that. But again, not probably able to speak to the outpatient aspect of that as much with insurance.
Thank you. This next question is kind of a two-part, so give you the first half of it. So, does inpatient treatment help with compliance? And then the follow-up question is, how often can this be done considering financial constraints?
Does inpatient help with administration, help with compliance? Um, so I would certainly say that that it could help because we certainly have oversight and have the ability to be there to ensure the patient, I guess, receives the dose each day. But keeping a patient in the hospital, unfortunately, does put them at greater risk of even just getting hospital associated infections. So, it's really the focus and reason why we kind of focus time and attention on reducing length of stay within the hospital. There's a number of reasons, but that certainly is an important piece of that. And then can you remind me the second part of the question, Cameron? I'm sorry.
No, you're fine. I'm the same way. The second part is how often can this be done considering financial constraints?
Yeah, and I would say we try to keep that down to a minimum, and certainly take it on a case by case basis. If this patient needs that support, and the options as we talked about, like oral options, or even getting like coming back in to receive treatment each day with IV antibiotics, if that's an option, or even going home with home health. That tends to not be the case as often, but we try to keep it down, and it's really just due to one of the big reasons that comes to the forefront for me is trying to keep the hospital associated infection risk down as much as possible.
And looks like we have another question came in. So, have you seen issues with inappropriate use of the IV line to inject illicit drugs?
In practice, unfortunately, it has occurred. So that's always a risk benefit discussion that that multidisciplinary team has with evaluating the patient and discussion with the patient, and kind of evaluating how to manage their treatment. But unfortunately, yes, that has occurred.
Well, it looks like those are all the questions that I have. But it looks like we had attendees from the Frankfurt, Lexington area. We had some from Paducah, Floyd County, from Murray, from the university, um, and then just all over Kentucky. So, once again, I did want to thank everybody for attending our session, our last webinar in our expansion series. We also wanted to thank Ms. Shana for sharing her knowledge. She was very knowledgeable. Um, but with all that being said, I want to give everybody back the time of their day. And so we will break for the evening. So we appreciate everybody for attending. Thank you.
Thank you.